I'm Professor Harish Nair, and I'm the head of Center for Global Health at the University of Edinburgh, and I also co-direct the WHO Collaborating Center on Population Health Research and Training. Now, introducing Professor Chatterjee. So, Professor Chatterjee is a professor of development economics, innovation, and global health at the University of Sussex. He did his PhD in public policy and management from Carnegie Mellon University in the US. Prior to that, he did his MBA from Indian Institute of Management in Calcutta. Prior to beginning his academic career, he started his career, in fact, as a journalist. So he was a journalist, a business journalist and analyst with the Economic Times Intelligence Group in Mumbai from 2003 to 2005, and thereafter went into academia. He is a fellow of the Royal Society of Arts. He's also a visiting professor at Max Planck Institute for Innovation and Competition in Germany. He was a visiting fellow at Stanford University's Hoover Institution until recently. And he's a fellow of Royal Society of Arts. His area of interests include economics of development, technology change, and global health. And he's published quite widely in reputed journals, including the Rand Journal of Economics. And he's co-authored a book, Flattening the Curve, COVID-19 and Grand Challenges for Global Health, Innovation, and Economy, which was published last year. So with that, I hand over to Professor Chatterjee. Chatterjee, take it away.
Thank you, Harish. Good morning and good afternoon and evening, everyone. I suppose there could be some attendees from outside of UK, so just respecting the time zones. Today, I'm going to talk about income shock and women's health spending with some new evidence from India. But before I jump into this talk, I do want to share how I started my journey as a health economist in global health. So I started doing my dissertation work on pharmaceutical economics. How do you provide affordable access to medicines while creating incentives for innovation when I was at Carnegie Mellon? And then I came back to India and started working on health systems, the role of physicians, and unintended consequences of policy interventions like price controls in the contexts of medical stents that we keep seeing nowadays in more free market settings. Not so relevant for the UK, where we have an NHS, which is anyways controlling the prices, etc. But in other contexts, price controls and interventions have had unintended consequences. I am trained as an applied economist, so I work mostly on secondary data sets, trying to find causal designs. And I also do a little bit, not too much, RCT work as well. And increasingly, I'm getting interested on technology in healthcare. So there are papers going on and projects going on artificial intelligence in healthcare, digital telemedicine, how technology gets diffused and adopted by health systems, where are the frictions there, et cetera, et cetera. So to make it a little bit of a fun today, what I want to do is I plugged in this paper and used Google Notebooks LM to create a podcast of why should we care about this paper? Why should we spend 60 minutes of our precious time today on talking about what we find in this paper? I don't want you to go through the entire 10 minutes and 35 seconds, but do listen to the first 2 minutes and see if you can get spurred up a bit about so what about this paper. Okay, and then I'll come back to the data, the novelty, the puzzle that I'm trying to get into with the findings, etc. And we'll go from there.
Hey, everyone, and welcome back to the Deep Dive.
Yeah.
You know, we love to dig into some really fascinating research, and, well, today is no exception.
That's right.
We're going to unpack some economics today.
Yeah.
That really challenges, I think, some of the usual assumptions that we might have about the relationship between income and healthcare, specifically in India.
Precisely. We often think, more money equals more healthcare, right?
Right.
This research really challenges that notion in a very surprising way.
Yeah, it feels very intuitive that more money, the more you can afford. Healthcare is a luxury. It's something that as you earn more, you can spend more on it.
Right.
But that's not necessarily what this research found.
Exactly. And that's where things get really interesting.
Yeah.
This isn't just about numbers, right? This is about understanding human behavior, cultural norms, and how those things intersect with economics, especially, in the global south.
Okay.
So we'll be looking at this specific policy change in India and how it affected particularly women's healthcare spending.
Okay, so before we get into the mind-blowing sort of findings of this, I want to talk a little bit about what makes this research unique. Because it's not just based on one data set. It's actually, there are two really interesting sources of information that they're using for this.
Yeah.
So the first one is, we've got this massive nationally representative household survey in India called the Consumer Pyramid Household Survey, or CPHS. And this basically tracks how Indian households spend their money month to month.
Wow.
And this was done from 2016 to 2020. So it's like this really, really detailed snapshot of what are people actually spending their money on, which is really cool.
Yeah, that's amazing.
And then the second data set that they have is they have detailed patient records from a chain of eye hospitals across India. So this is from the LV Prasad Eye Institute. And they were able to use that data. This is really interesting.
So I think I gave you away the punchline of the paper, why this paper may be important. I think there's a big puzzle whether healthcare is a luxury good or not. And when you get wealthy, if you spend more on healthcare or not. And that's the puzzle, the macroeconomic puzzle that I'm trying to get into. And then the second part of the story is that I'm using two novel data sets. One is an administrative data set that pan-India, but if you're not satisfied with it, the other is electronic medical records data set from a particular hospital system. And we are trying to create some trust in the research findings through these alternative data sets, saying that what we pick up in terms of counterintuitive behaviors from how women spend on health when they get an income shock, a positive income shock, is something that we should be paying attention to in the context of gender and global health. The fun thing is that this is not exactly a RCT with a conditional cash transfer. So we use a quasi-natural experiment where the government changed something in terms of money available in the pockets of formal sector employed women. And then we can see the translation effects of that in health and non-health spending in these two databases. Another fun thing is that when I present this paper to other LMIC country colleagues, like there's a colleague in Pakistan who was like, hey, I need to get you this data from Pakistan, and I want to see, is this the pattern of behavior in the way women are spending in healthcare in Pakistan as well? So we suspect that what we find in India might be internally valid in the context of these two data sets, but could have some behavioral generalizability in other LMIC countries that I want you to take away from the talk today. All right, let's go to the macro puzzle. So this is a picture from the World Bank where I plot on the x-axis time, and on the y-axis how these countries have been spending on health as a share of GDP. Okay, and as you can see that as countries, the obvious suspects here, China, OECD countries, etc., as they have gotten richer, they have spent more and more on healthcare, but not India. So in India, the blue line here will show you that it's actually falling. In fact, even after COVID, despite lots of public pressure to improve the national health expenditure on the budgeting front, the Indian government hasn't really responded and spiked up the health expenditure. Okay, so that is a puzzle from the context of a policy decision, but also we wanted to see if this means something because of certain underlying micro foundations or behavior that's not entirely rational in economic sense, which is where we get into doing a correlation between the relationship between health and income. So x-axis here is basically how income is changing, again, from cross-country, cross-years data. And what we'll see here is a negative correlation for India between income and health, the same point that I was trying to highlight in the first picture. So why does India appear to be an outlier to this conventional wisdom? That's the macro question I'm trying to get into with this micro causal data study that I'm now going to show to you. So overall, what we want to show is the causal effect of income shock on health expenditure at the micro level and for female-led households. We exploit an unanticipated policy shock that resulted in employees' provident fund contribution for women. So just like here, the government basically contributes to your salary contribution into the pension fund, but there was a policy change where this, to motivate more women's participation in the female labor force, the government said, we will contribute more. I will take out less from your salary. I will spike up your disposable income if you are working in the formal sector and if you are in a certain wage band. And the moment that happened, we could use that to explore whether those groups of women who got treated with these policies changed their behaviors in how they were spending on healthcare vis-a-vis non-health expenditure, and whether that got borne out, not just in a nationally representative households data set, but also with hospital data. And our basic big picture finding is that very counterintuitively, but yet I think understandably, given the cultural and the social norms with which South Asia or a large part of these LMICs are operating, a decrease in overall spending is observed on healthcare with this policy change. And it indicates that the effects of income on healthcare could be context-specific, driven by gendered effects, and that has important policy implications for global health, broadly speaking. There is a long literature here around this. So developing economists, not just in health, but more broadly, have talked about income effects on health with elasticities that vary between less than 1, higher than 1. So if you're more inelastic, basically the idea is that you are treating health as a luxury good. And if you're locked into spending your health expenditure in a certain way, you don't really want to change it that much if you have an elasticity less than 1. And then there are conversations in the development economics literature around how women can actually be recipients of these conditional cash transfers or income schemes, because there are not just direct welfare effects of that on households, but there are spillover effects, positive externality on giving women money. And this has been tested in our city settings, in Latin American context, in Africa, et cetera, et cetera. So that's one development literature that we are thinking about. I will jump into talking a little bit about what we do in the study. So the policy that I was talking to you about is a policy that happened in February 2018. There were certain groups of females who were formal sector employees in a certain age band that were beneficiaries. And essentially what I'm trying to do is, if they were beneficiaries and if they were in the treatment region post-2018, can we see and observe how the outcome, which is how they spend on health and non-health expenditure, vary, controlling for all else in the system? Okay, so that's, forget the equation. The basic intuition here is that if you have a quasi-natural experiment where some groups of individuals are treated with a spur in their disposable income, but other groups aren't, then controlling for all else, does this really translate into better health allocation in health expenditure? Okay, so that's the story that I want to walk you through with the findings that we have today. And this is the model that we take to the households data that the podcast was talking about. So if there are economists in the room, they were saying, wow, it's an amazing data set. It's not really an amazing data set. There are issues with that data set. Economists are aware of that. There are some selection biases. There are alternative data sets in which people triangulate apart from the one that we use. And there is a temptation from my side basically to do a large-scale national survey. Like if I can raise grants money, I can give women money and see how they behave, follow the household over time, and see exactly how this pans out in a more with less sample selection biases. But that may be, but I think what we have here is a period from the data set, which is 2016 and 17, and then post-18. And then there are these observable treated women who were recipients of this policy's favors. And we see what it does to health and non-health expenditure. There's some interesting results on how, with this shock of better incomes, women may not be spending on health, but they are spending on health enhancements. It's almost like health-seeking behavior, where they are potentially buying nutrition or getting stuff for themselves or for the households, which is getting picked up with this shock that they're seeing in the household level. All right. So this is the data set. We now have chatted a little bit about this. As I said, the income allocation decision, we can pick up from the data set how these households are spending on food, clothing, intoxicants, education, etc. The main outcome variable we are testing this on is households, how they're spending on healthcare in logs. I'm not going to deliberate too much on the other details of this because there is like a bunch of things to be shown from this data and then the other data set as well. But bear that in mind that the real advantage of this data set is you can track not just health expenditure, but also non-health expenditure. Okay. Now, who are these treated groups, right? So the government policy is a little fuzzy in the sense that it says that it will go to women of a certain age band if they're employed in the formal sector. And if you take that to the data set that we have, we can only identify certain types of households who are eligible to be enrolled into this policy's incentives, right? So our data captures gender, age, occupation, education, and family size. And there are gender groups. So we can identify households that have more female members than male members, which is like these are households which are female majority households. And then we can do some robustness checks on this. So there could be households where there is a single mother. There could be households where it's all females in these households. And then we have to make sure that these households are also working in the formal sector and the main female in the household is of that age band, just getting eligible for the policy's benefits. Okay, so we use all those robustness check with alternative definitions of treatment groups. And then we pick up the effects of that on the pre and post shock period, etc. So I think I've talked about this. I don't want to show you too many equations. Okay, so outside of that national data set of households, the other concern that would obviously pop up is, hey, you are looking at this stuff, but how about controlling for the health status of females who are getting eligible for these policies, right? So this household does this nationally representative data set doesn't help you control for the health status of women a priori before they got eligible for this treatment. And also, they doesn't show you what kind of health insurance schemes they are subscribed to, private or public. Those are important controls that need to be in the system to say that everything is about this policy treatment that's happening in the setting that we are studying. So for that, we turn to this micro data set. Now, it has its issues. It is a micro data set for eye health. So L.V. Prasad Eye Institute and Dr. Rajan Narayanan, who is my co-PI and PI with the Wellcome Trust grant in Hyderabad, India, was very kind to share this data set with us. But it is only about eye care. It's not about cancer care or cardio care, etc. But at least in this context, we can control for the health status and the exposure each patient that flows through that system is subscribing to in terms of health insurance. So the concerns that I had with the nationally representative household data set is somewhat ameliorated with these two additional controls from this particular data set. And then there are information on out-of-pocket expenditure, information on gender, marital status. You can identify whether a female visitor is in the formal sector, government or private service. We pick that up, and then we see how this translates into how they're spending on eye health. Okay. Now I'll jump into what I'm seeing in the data, given this setting and given this question. So here's what I'm seeing in the data. This is the main result. And you'll see in the national data, negative relationship throughout. Once the beneficiaries are getting this policy exposure post-2018 on health, on medicines, on doctor fees, and these are like complex systems that are getting estimated econometrically, where there are other controls as well. So these results are pretty stable. And then you have stuff like hospital fees are actually going up. There's no effect on insurance premium. There's no effect on medical tests. And there is this very cool effect on health enhancement expenditure. So maybe they're going to the gyms, maybe they are buying more nutrition stuff, but this is all getting picked up. So the bottom line is that if you translate these statistical coefficients, it shows that there is, with this policy on the beneficiary woman, there is a decrease in 11.6% on total health expenditure. There's a decrease about 9% on medicine expenditure and a 10% decrease in doctor consultation fees, and somewhat potentially explainable through women's health conditions are priority, which is where we will have to come back to the iSmart data from LV Prasad and control for it. So these are the main results. Then what are they doing if they're not spending on health, right? That's an immediate next logical question you are thinking. If they have more disposable income in the households, where are they spending the money in? So what we are picking up, interestingly, is a pretty strong effect on education, this model, a pretty strong effect on hygiene and beauty, and there is a decrease in intoxicant consumption, I mean, temptation goods consumption that's happening as well. So it's almost like women in the households who are beneficiaries of this policy's effects on disposable expenditure are being a little more sensitive and thoughtful about how they're spending their money on education and on health enhancements, and a little more sensible on not spending on temptation consumption. Okay, so this is where the money is potentially flowing, if not on health, right? Can I help you? Yeah, sure. No problem. Not a problem at all. All good? Sorry. No worries. All right. So all that I've shared so far is, okay, health expenditure is going down. Non-health expenditure in education and in health enhancement is going up. In this nationally represented data set, it controls for other confounders, and the results seem pretty stable and robust. Okay. Now, the question is, you can't just measure health in absolute terms especially in health economics. I mean, you want to think about at the household level, how are you thinking about health as a priority for you in the household? So you want to normalize this expenditure on health with your overall income in the household. So we run a regression, a model where we see how health evolves as a share of income, and it's very consistent with what we found earlier. Health not only decreases in absolute terms in terms of expenditure, but it's also falling when it's modeled as a share of the income. So the importance of health, surprisingly, despite a health and a positive income shock, is seeming to getting dissipated in some sense with this treated group of participants in this study. But there are other things that are getting picked up given the way the health system is structured. So you'll see that medicines expenditure also are suffering, doctor fees are suffering, people potentially are walking more into hospitals and doing out-of-pocket payments because of certain shocks, let's say from medical emergencies, and the health enhancement effects as well. Now, some of you might be aware that in India, there is this interesting variation these days of certain states subscribing to the federal health insurance scheme, but other states not. And there's a political economy aspect to this, why certain states are allied with the federal health insurance scheme and other states are not. So the politicians are fighting with each other and saying who is doing better for population health, etc. So you can actually split the data into two groups of states, states which are enrolled in this federal health insurance scheme called PMJAY, and those who are not enrolled. Okay, and you can see that there's no effect of that. So the basic negative effect on health expenditure with the income shock persists even if you are splitting the nation into states which are enrolled in the federal health insurance scheme and not health insurance scheme. Okay. Since I will show you the LV Prasad data results in just a bit, I also wanted to check whether the results hold for states where LV Prasad is itself present. So just to give you some context, and some of you might know this, affordable healthcare has seen a lot of social entrepreneurship in medicine in India, starting from LV Prasad to Arvind Eye Hospital to Narayana Rudalaya in cardiac care. So certain states are more covered by these socially minded clinician entrepreneurs than other states, and especially in southern India. So if you are going to see a difference in behavior between these states where social entrepreneurship, not-for-profit health systems are operating in certain clinical conditions, that should be controlled for in our baseline findings. And this is what we are trying to do in model 2, which is that let's see what the difference in behavior may be in how we are spending on health for the states where LV Prasad is operating and vis-a-vis other states. And we are seeing the same story here. So it's almost like a secular national effect coming out of this policy, whether you are enrolled in the National Health Insurance Scheme or whether you are having better access to health because of social entrepreneurship. Okay, so I mean, to be honest, I was surprised that there are no variations in these results. I expected some loss of statistical significance, some reduction in sizes of these coefficients, but I was like, this is something solidly happening, and there's some behavioral ways through which we model human behavior here that needs to be gotten into. I mean, I don't do this in this particular paper, but I've been thinking about how to think about how women spend on health and other irrational tendencies there that we need to capture, especially in resource-constrained settings like in LMICs. Okay. Other heterogeneity groups and robustness checks also exist. So you may say that, hey, do these effects persist after 2018? We extend the data till March 2021. Looks like it does persist. I'm not showing the results, but the results are there. Laura can circulate the slides after the talk. We try with households that only have female members. This is a rarity in India. It's a very patriarchal society nationally, generally, but there are certain regions which are matriarchal as well. And you can pick those regions and that subsample in the data to see if the results change. Results are not changing. And you might be wondering what's happening with households that have predominantly males in them. So this basically strengthens our causal arguments, right? So if you take households which have just males or male-dominated households, we have a falsification exercise which shows that the basic result, that income falls in, health expenditure falls for women getting an income spike, actually doesn't hold true for men when you do this falsification exercise, okay? Micro case findings from the hospital data. So the hospital data is very interesting because I don't know of any other electronic medical record system in India, at least, that allows you access to that data, of course, and is capturing it so rigorously since 2016. Every time a patient is entering into, let's say, an infirmary here, it gets captured. Who is the patient? The demographics. For what is this patient here in the hospital today? The gender of the patient, the occupation and the health insurance status, and then the doctors who are seeing these patients for which conditions, and they're starting eye health and they're ending eye health in terms of visual acuity. So it's a pretty comprehensive data set, and I'm hearing that NHS UK is now going to create a similar data set here. They have the data. They haven't made it accessible to researchers. That's the real challenge here. But LV Prasad thankfully makes it accessible to us. And what we see is that on the right, there's this additional impact of expenditure for healthcare and surgery expenses as observed in this electronic medical record data, or out-of-pocket expenses have a deep fall, okay? But not so much for investigations. So if you split how they are spending on health in the electronic medical records data set, it seems like when it comes to acute interventions like surgery, there is a deep effect, but not so much. And on the left, what we see is this effect on married females, where similar effects that we have on the broader sample exist on females who are in the electronic medical record for married and unmarried in terms of their reporting to the database. So the micro data set is broadly consistent in its findings with the macro data set. And let's remember, the reason we are going to this micro hospital data set is we wanted to control for health insurance status and ex ante a priori health status of these women before we can say that all eggs are on that income health relationship basket, okay? Very interesting result, and I think this should actually spin out from this paper to a separate paper. So as many of us know from global South and South Asian contexts, when you become marriageable as a woman, you start spending on enhancing your physical profile, and especially if you have issues with your eye health, you take some surgeries, you do some surgeries to get rid of spectacles and glasses and stuff like that. So we can actually capture stuff like this refractive surgeries, strabismus, more like these are surgeries of style rather than need, okay? So what we see is that with this shock, among the beneficiary women in the electronic medical records data set, there is a deep impact on the more important surgeries like cataract, as well as oculoplasty and retinal surgery, which tells you that people are somehow delaying those style-related expenses in eye health than they would have otherwise done if this income shock was not there. Now, this has pretty interesting social consequences in the way you participate in the labor market, your household health, your status as a woman in society, et cetera, et cetera. So it doesn't stop there, and we, I think, need to dig deeper in these results and do more about these implications for how women are thinking about spending on health on need-based rather than style-based surgeries. So those are my core set of results in the macro data and the micro data. And remember, the puzzle we are trying to solve is, why is India not spending enough on healthcare, whereas other richer countries, as they're getting richer, are spending on healthcare? And could we have some micro social gender-driven intuitions around this and explanations around it? And that's what we are trying to get with this result. So there's an interesting new paper in economic behavior that is circulating now, which talks about cash transfers having these weird effects on how people are spending money when they're given money, and especially when women are spending money when they're given money. So we are going to borrow the theoretical insights from that paper, and they are talking about women having skewed preferences towards consumption of certain types of products. There are some new stuff that's going on. The results are not yet out, but I'm aware that developing economists in the US are running some RCT experiments where they are treating households with women with cash transfers, like you said, Harish, and then seeing how they spend on health versus non-health expenditure. And we are keeping an eye on that evidence because I think it would bolster our evidence in India. But more importantly, beyond evidence, we can theorize a bit on how to think about gender and global health when we are making recommendations to policymakers, especially post-pandemic, let's say, in thinking about national healthcare expenditures. Okay. Forget this economics jargon. Bottom line is that these are results that you should pay attention to, because it's very counterintuitive, and that policymakers may be thinking that if you give money to women, they would be starting to spend on health. That doesn't really translate. So it's almost like an unanticipated set of results getting borne out through two types of data sets where we control for confounders. The results remain robust. And it's juxtaposed in the bigger macro puzzle of why, when countries get rich, they're not spending enough on healthcare. So that's my humble contribution and submission to you to ponder. I'm now very happy to take some questions.
And I think you partly answered this. So this federal health insurance, the Ayushman Bharat scheme that was launched in 2018. So, and your data are from that period. And so you've looked at states that have introduced the scheme and the states that haven't introduced the scheme. But the data set you're using is from the Employees Provident Fund. So a lot of those people who may be beneficiaries may be people who are with the central governments. I'm just trying to think that I think people's expectations and behavior changed quite a lot post-introduction of this scheme, because people thought, okay, it's ₹500,000 per family per annum that is available. So that's good money that's there. So if I'm getting extra, maybe I spend, and maybe I spend more on educating the children. So are these children being sent to private schools rather than state schools? That's something to think about, because in India, that's a value product. But overall, that may lift up the income of the household over a longer term. They may also be consuming better food, which I think is sort of difficult to capture, and maybe also supplementation in terms of nutritional supplements or vitamins and things like that. That may be another behavior change that may be happening. So that may be something to sort of ponder about and think.
Yeah, so quick responses. There were a lot of things in your question, so thank you for it. My first response is that a blunt test of whether the things were getting borne out in the federal states, I mean, the states with federal health insurance versus the others, looks like it's getting borne out there. But we also know that it was not a one-shot implementation of this policy. It took a staggered approach and a lot of like public discussions when whether states are going to adopt this federal health insurance policy. So yes, people's behavior changed with the expectation of ₹500,000, but didn't change right away, even in those states that adopted this scheme. That's one. Second, I absolutely agree with you that we can actually split the education data to see how they are transferring the expenses towards private versus public education. What I may not be able to do is to completely say that this is that scheme versus our focal policy, which is around the pension fund. It is a bit of a concern, but at the same time, I think what we can do is we can dig into certain states like Kerala and West Bengal, just those data sets. And thankfully, this national representative data set has households participating from these two provinces, which are not participants in the federal health insurance scheme, and then explore how these things are changing in these two states vis-a-vis the rest of India. So good question, somewhat of a answer that I have for you, but I know it's not completely satisfactory. We have to do more on this.
Thank you. We have one question from the audience, which is they're saying it's an interesting study. What might be the role of aspirations and political freedom here?
In what sense, right? So if we are discussing that political freedom and aspirations are going to mute the way people allocate health expenditure when they get an income fillip, we are able to control for regional effects in the system. The splits between PMJAY and non-PMJAY states is in some ways proxies for states with more and less freedom. The results are going through there. We have tested, I was telling you that there are certain households which have like female majority households and different other groups where there is, when you split those groups, you can say that those are groups of households where not only is the female a majority, but there would be more freedom of expression versus other households where there will be patriarchal norms. And we still are getting solid results. The results are getting falsified with the male-dominated households, like in North India, for example. So in some sense, there is a role perhaps, but that's not the real focus of our study. We are trying to control for those other things in the system and then say that, you know, there's a big question post-pandemic on how countries should think about health expenditure. I was talking to Ruth this morning about the long COVID problems and macroeconomic productivity in Scotland. And should governments come and spend in that context on health expenditure, and especially to certain vulnerable groups? And how should you design policymaking in that context? It is in that question that we are trying to answer, controlling for the political freedom and freedom of expression kind of conversations. So that's my quick response now, but that could be a separate paper, of course. I have paper on political economy of vaccine spendings and stuff like that, but you can only do so much in one health economics paper. So
Thank you.
Thanks for the question.
That's quite good answer and quite helpful. There's a question on, can you talk about the effect on rent and bills in the data set that you looked at? The person posting the question says that they think that went down too, which they think is quite weird.
Well, there could be migration effects. So as we know that there are national schemes that give you affordable housing in India during this time period. So potentially they are, I have to go and test in the data this, but potentially households are subscribing to these national affordable housing schemes where they're coming out of the rent systems and are getting free houses. That could be one explanation. The other is that if we know that in India, there's a lot of migration happening from the poorer parts of India to the richer parts of India for job purposes. And if that's happening, then is this the reason why they are should be spending more on rent in that case, but I'm not picking that up. So I have to go back to that part of how migration can be controlled for. But my initial response is that Potentially this coming because people are also getting affordable housing, which is resulting in them switching from expenses in rents to, let's say, education per se. And if you know the pecking order of preferences for Indian households, education is a big thing. 30%, I mean, there are estimates floating out there. 30% of household expenditure is on education, a little bit more on healthcare, and the rest, like, people amble along, right? So I'm not so surprised by the rent results, but it's a fair question. I do have to dig on whether there's a migration effect or there's this affordable housing policy that is creating these results that we have.
And the another question is, could the reduced spend on medicines and doctors' fees because members of the household became healthier after they received the income shock?
Which is why we have to control for health status in the microdata. And the other thing that's going in the background is there's a national generic pharmacy scheme where you get very cheap medicines. So you don't have to pay that much out of pocket for these generic medicines. Could that be driving the reasons why people are not paying to private pharmacies to get these medicine spending and doctor fees? We can test that. We haven't tested that properly, to be honest, and we can test in certain states where there's far more diffusion of, like Gujarat, where I was working before coming to the UK, has a big has a big state level generic pharmacy scheme. So are the results stronger there or weaker there is something that we can go back and test.
Yes, and I think, again, as part of the Ayushman Bharat, generics have been made widely available, and a lot of people, including wealthier households, have now moved to generic medications, and that has cut down their spending on medicines overall.
And therefore, it's important to really rule out the federal health insurance scheme effects and say it's this thing.
There's a question around whether in your data set, can you look at whether the distance traveled to access healthcare, whether that, is this positive income shock resulting in more income to be able to, or spend to be able to travel further distances to access healthcare, which people tend to do, particularly if they're accessing private healthcare?
Absolutely. So this is, we know who work on health in India or South Asia, that this is a big issue because the opportunity cost of living one full days of wages and going and getting yourself treated in hospitals is substantive for households. So the LV Prasad micro electronic medical record data tells you which PIN code you're coming from and the hospital system that you are accessing. So you can compute the distance traversed by every patient in that data, and we control for that in our results. So when you control for that, the results still are holding strongly, which means that that is not what it is like creating confusion in the basic results that we have on income and health. So we have controls for that in the micro data set, in the LV Prasad data, for distance people are traveling to get access to private health. And yet the results are going through despite that.
Right. There's another question on threshold for private education spending, and they're asking, is there a certain income level before the shock where people couldn't afford it, but then after this positive income shock, they're able to afford it? Do we know of any kind of threshold of what a family would be willing to spend on private education?
Anecdotally, yes, but I'm hesitant to say, like, put my finger on a number and say this is the amount, okay? Anecdotally, being a dad, I have a sense of how people are spending around me since I was till recently in India and thinking about this for my child. But I have to be more careful about giving a number in responding to that question. So I'll hesitate from doing that.
Thank you. The other question is whether, overall, so I was thinking, for example, you said that male-dominated societies or male-dominated households, and so North India versus South India. South India, where women either is a female head of household, or you've got females who are intrinsically involved in decision making.
Right.
And that's because of a long-term awareness and cultural practices. And in north of India, where the women are generally not involved in decision making. So
allowed to be involved.
Yeah, allowed to be involved. So it may not be just the fact that the women, the men are dominating those households, but whatever women may be earning,
Yeah,
they have to basically hand over to the male
Yeah.
members, and the male members will decide how that money is going to be spent,
yeah.
and whether that then gets spent on other
Yes.
luxury goods, i.e., intoxicants and things like that, not even education, so to speak.
So your question is,
Whether you see that, have you been able to see whether in north of India, if whether you see the sort of the falsification of the data, where the women were, if we were bringing in the additional income into the household,
yeah,
where that got spent, whether this was on other products that may be
yeah.
enhancing health, but not healthcare as
So I
such.
haven't tested it explicitly on North Indian households, but the PMJI households are majorly North Indian households.
Okay.
So the federal health insurance scheme was big time diffused in the northern Indian states, given the way they voted for the incumbent government, but not so much in, as I said, southern and some eastern states. So in those states, we do see the effects are persisting. But there are other states also, like Manipur, for example, where we have matriarchal societies, and they appear in my data set. So we can go do the check in an alternative type of a data set, like you said, where there is real agency with women in the household to make decisions and see what, even if there are few observations, if I can have that in my results, I think it really bolsters the causal arguments that we have in the analysis. So I haven't done this, but I take this point. We are recording this, right? I will get this comments to test later on. Yeah, thank you.
There's another question. Did you look at religion, stratify your results by religion, see whether that has any effect on your overall?
Haven't, but definitely plausible that there are effects of, like there are interaction effects of religion.
Yeah.
So I have
Maybe caste as well,
yeah,
possibly.
religion
with,
slash
with,
caste.
yeah. The other thing is whether, so what's the overall take-home message? Is this a good thing that if you give money, more disposable income to women, will that doesn't necessarily translate into healthcare spending? Is that a good thing or a bad thing? What is your value judgment on it?
I think my value judgment is that nations can't just bluntly ramp up health expenditure and hope that uh, populations will get healthy. You have to pay attention to the margins at which other things are interacting with the decision making in these households to make sure that health seeking behaviors are also changing. Because if you're not keeping an eye on the fact that you're giving more money in the hands of women, but they're not able to spend on health, then you are losing the vision of a policy intervention. So therefore, I would say that if this is the story, let's also take care of social norms, stigma issues, or have sub-national health data recording system that shows you through an evidence-based way that even if you give money in the hands of women and they're not spending in healthcare, they may have broader negative productivity effects in the household. So, I mean, I know, for example, in my household, if my wife has a sick day, for example, life stops a bit, she takes care of the household a lot. And I'm being completely frank here. So that measurement of household productivity when women are suffering and are not able to pay attention to their own health is something that we should be paying attention to when we are designing policy making, and not just throw bluntly money in the hands of certain groups of people thinking that will bring in better health of nations. So that's my broader judgment, value judgment here from these findings. If that makes sense.
Yeah, that's helpful. Thank you. There's another question is whether, so whether these women, particularly from the formal sector, are different from those in the informal sector. Are they better off, for example, and whether the women who are in the informal sector would be expected to behave similarly?
This is why we have the model where we are normalizing health with income. The dependent variable is health as a share of income. So if they are better, that accounts for the fact that this excess agency they may have because their incomes were ex ante better is going to be normalized because it's now shared out as a share of health expenditure. What was the second thing? Education, is it?
Yeah.
So we have education control for whether somebody has a PG degree. We have data for that, not in the microdata, in the LV Prasad data, but in the household data set. And the results are going through despite controlling for education.
Okay, that's helpful. There's a question whether are you aware of any qualitative studies exploring women's reasoning and motivation behind what you're sort of seeing?
No, but you know what? I was telling this to Ruth this morning that there is a maternal mortality app that was diffused in Mumbai. And what we observed, it's a COVID study, but what we observed is when women get more agency in their households, and then there are text messages flowing in through the smartphones at home, and the men in the households are in the households, they are paying more attention to those text messages, and their progression in terms of health seeking behavior during the trimesters and post pregnancy are impacting, are getting better. So in that context, I think that there's a lot to be said about how technology can be folded into these conversations in tracking how women are spending their money on health and non-health, and using that evidence. The problem generally in most of global south is that you are scared about digging into evidence because evidence gives you hard answers, and politicians are afraid that they will lose votes as a result, perhaps also in this part of the world as well. So I just want to encourage you to see the evidence from the perspective of being very science minded and health economics minded in these conversations, than just being policy like a hand waving thing and get some short run votes and run away with your stories. So
Okay, there's one question which is quite interesting, whether how is health, not health spending, but health per se in India changing as people are getting richer?
they're getting more obese, they are ordering more food over their apps. The younger are a little more conscious about vegan diets and green diets. There is a demographic slowdown in the sense that people are getting older. I see a huge, in cities, I see a huge preponderance of nutrition apps and fitness apps and folks like that. So it's a weird conundrum, which is that you have city and non-city India. You have these bad behaviors in health and these non-bad behaviors in health. And in the aggregate, where it ultimately stands in terms of health status from macro data is very unclear, to be honest. And lastly, I would say that vulnerable groups are suffering. So we moved from India mainly because the air quality is a real challenge throughout India, of course in North India, and 1 in 3 children are having asthma, it's really problematic for women's health in terms of how public and private spending is happening for healthcare and access to healthcare. So health in India is standing at a very weird inflection point, where there's a lot of private entrepreneurial interventions, AI, technology, but people are not taking a pause in terms of these idiosyncrasies that are happening in how health is moving in India. And not just India, I would say, entire South Asia, to be honest. People are looking at India and how it's evolving to learn and sometimes not learn. So I would say it's a lot for global South in some sense as a standard, as a chaotic standard. Let's put it at that in terms of health tomorrow.
Thank you. And before we end, just a thought for you for further research. And I think what your findings that you got, you may want to explore this further with the help of a qualitative study. I wonder whether the demonetization, so these were large denomination notes, 500 rupee and 1,000 rupee notes that were withdrawn from circulation at the stroke of pen. So this is like within 4 hours of the Prime Minister of India coming on television saying the notes are being withdrawn from circulation, the notes were no longer legal tender, people were left no money, particularly women who were keeping disposable cash under the mattress or in biscuit tins. Suddenly overnight, the women were left with nothing. And whether that changed their behavior when they got disposable income, they start thinking whether, and this can only be uncovered through a qualitative study. So I would encourage you to sort of follow this up with this quantitative data with some qualitative study in sort of similar populations to understand whether that may have changed, particularly into 2020. And if you're using post-2020 data, you may also want to look at when the government started giving these free rations. And in some states, the free rations were given even to middle-class families. So we're not talking of people below poverty line. So reasonably well-off families, my own extended family back in India. Almost all of them got, particularly in South India. This was a welfare scheme that was launched and given for 2 years almost during COVID. So no one had the need to spend anything on food grains.
Mm. No, the demonetization thing is very important because I think it has anecdotally changed human behavior and health spending behavior. There are Bollywood movies on that as well. So it's worth doing a qualitative study in that space. I'm a little fascinated by movies and its effects on health seeking behavior. I was telling this morning that when My Name is Khan, the Bollywood movie, was released, I have a health economics paper which talks about how it destigmatized consumption of antipsychotic medicines in the context of Asperger's syndrome. So there's much more than policy that can do through these edutainment effects that can be complements to how we think about health in Global South.
Thank you. Very interesting presentation, interesting series of Q&A. And now we come to the end of this seminar. Thank you all for
Thank you very
attending.
much.